Service and resource descriptions are a key component of needs-based mental health planning. This video will introduce you to the service and resource modeling used in the framework model. These descriptions detail the types of mental health care required for the Australian population and outline efficient standards of service operation required to deliver this care. When used together with the epidemiology and care profiles, we can then calculate the resources required to deliver adequate mental health care for the Australian population. The 5 aspects of the service and resource modelling are the taxonomy, workforce details, funder types, care profiles and top-ups, and modelling parameters. These inputs have been developed over the past decade in collaboration with over 250 service providers, academics, and service planners. The service and resource descriptions are also regularly updated. These updates are based on best available evidence and the release of new service models in line with the framework development cycle. Firstly, the taxonomy outlines the full spectrum of functions required in a comprehensive mental health system. This includes services ranging from digital interventions through to specialist clinical treatment and mental health community support services. Each state and territory structures their mental health services differently. The taxonomy provides a common language and clear definitions of core mental health service components and functions. The taxonomy contains 5 streams of mental health services: mental health promotion, mental illness prevention, primary and specialized clinical ambulatory or community mental health services, specialized mental health community support services, and specialized bed-based mental health care services. This is a condensed version of the taxonomy. Each stream of the taxonomy is further divided into service categories, elements, and activities, which each relate to a specific aspect of mental health care. Let's look at some examples of this structure. Zooming in a bit, within the primary and specialized clinical ambulatory services stream, there is a service category for consultation liaison. Within this category, there are service elements for different types of consultation liaison services. Within the specialist rural outreach service element, there are a variety of service activities. Within the stream for specialized bed-based mental health services, there is a service category for acute inpatient services. Within this category, there are service elements for different types of acute inpatient units. Next, details about the workforce required to deliver each service accompany the service elements and activities. This information is needed to produce resource estimates. In the framework, workforce is broken down into categories and types. Workforce categories are broader and include the professions medical, tertiary qualified, vocationally qualified, and peer worker. Workforce types are nested within categories and reflect the individual professionals who may deliver services. Sometimes, services are modeled as needing to be provided by one specific workforce type, such as a registered nurse. Other times, only the workforce category is modeled, such as tertiary qualified, meaning the service can be provided by any appropriately trained tertiary qualified professional. The next important consideration is the funding for each service. This is especially important in terms of helping planners in identifying their likely areas of responsibility within the model. As a result, funder types are used. The funder type indicates the body deemed primarily responsible for funding and administrative oversight of each aspect of the model. It represents a national average of the current mix of services rather than an optimal model. For example, the state funder label is allocated to certain bed-based and clinical ambulatory services. Next, care profiles bring together all of this information to describe adequate care for each need group. These detailed inputs allow calculation of the resources required to meet the service needs of each group. Care profiles are designed to inform a system-level perspective and allow for calculation of overall resources required. They do not provide individualized care pathways. Care profiles have been developed based on best available evidence and expert consensus. The level of care specified in a care profile is deemed adequate to meet the service requirements of the need group on average. Anything less is considered unsatisfactory. Care profiles provide information on the care required for each need group, including the service types required, the percentage of the need group who require each service type, the average number of occasions of service for each service type, the average duration of each service occasion, the workforce required to deliver each service, and the funder responsible for each service. Finally, the framework includes a series of modeling parameters. Modeling parameters include the desirable workforce mix for each team-based service. These are based on staffing profiles from example services around the country. Operational parameters are also included, such as bed occupancy rates, annual readmission rates, salary on costs, and overhead costs. These parameters are modeled at desirable and efficient rates. The modeling parameters, used in combination with information from the care profiles, help to define resource estimates, such as numbers of required beds, staff hours, full-time equivalent staff required, and estimated costs. The components of the framework model discussed in this presentation describe the core services and associated resourcing used to generate estimates for mental health service planning. Further details on this content can be accessed in the Introduction to the National Mental Health Service Planning Framework and the technical appendices within the documentation package.